Medications play an important role in the treatment of many mental illnesses. Learn about their benefits and limitations from a couple of experts who I just happen to have sitting right next to me. It's our medication show next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. When we talk about specific mental illnesses on this show, like ADHD or bipolar disorder, we include information about the role of medications in their treatment. But tonight, we're turning that equation upside down, and we're going to be talking about medical interventions in the treatment of a variety of psychiatric disorders and how those interventions may be different depending on whether the person being treated is a wee one, a little kid, or an adult. You can be a part of tonight's conversation by calling the numbers on your screen right now. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. We'll be answering your questions throughout tonight's show. My guests tonight are Dr. Steve Bauer, the medical director at the Human Development Center. He's board certified in child, adolescent, and adult psychiatry, and Dr. Elena Metcalf is a board certified child and adolescent psychiatrist with Essentia Health. Although she primarily treats children and their families, she's also board certified in adult psychiatry. Thanks to both of you for being here and joining us tonight on Speak Your Mind. So I think here's what we're going to do, folks. We're going to talk about a few classes of mental illnesses. So we're not going to, we can't get to all of them, but we're going to talk about a few classes and what the medical interventions might be with them. If you have other questions about the medical interventions of other disorders, it's okay to call those in too. So the first one I think that we're going to start with is ADHD. And just so that everybody knows what ADHD is, attention deficit hyperactivity disorder, typically presents early in childhood initially. In fact, that's one of the diagnostic criteria, that it has to present early in childhood.
Correct.
And may be primarily inattentive, primarily hyperactive, or a combination of the two.
Yes.
And so, medical interventions.
So, ADHD treatments with medications are the most noticeable effect that is positive when we have the diagnosis right, and most of the first line treatments are what we call stimulants. So stimulant or medicines that increase someone's focus include kind of three basic medicines: methylphenidate, amphetamine, and dexamphetamine or dexedrine. All have many names because the companies that make them use different long-acting ways of distributing them. So Concerta, Daytrana patch, Mentadate are all methylphenidate products. Adderall and Adderall XR are mixed amphetamine salt, and then dexedrine is a generic product, so most of the things aren't called something else, though dextrostat or other names that include dex usually are using dexedrine. And those are the stimulant treatments, and then there are non-stimulant treatments. And so there's kind of the medications that are more like the stimulants, so Strattera or atomoxetine, and then bupropion or Wellbutrin are two medicines that work on the same receptor slightly differently. And then there are medicines that work more on hyperactivity. And those are some blood pressure medicines. If you look them up, is where they're listed because that was their first use. So several different kinds of things, and depending on the symptomatology, you talked about the different kinds. What's most bothersome, what's interfering, those are things that we might use one or two in combination, depending on the symptoms and the response.
So, Dr. Metcalf, when you have a child who has a bona fide diagnosis of ADHD, is this a mental illness where we are almost always saying, yes, this is something that's going to be best treated with at least medication? It may also include psychotherapy. or family therapy, but that where you absolutely want some medication?
Yes. ADHD is one of the medications which is most clear-cut that there is clear benefit. For any psychiatric diagnosis, there needs to be the criteria being met that there actually is some kind of impairment, meaning it's affecting their, not just their schoolwork, but their relationship development, their getting along with people at home. What we look at ADHD, it's a deficit in what we call executive function, which is the ability to plan behavior. So part of it is being able to control your impulses. It's also being able to plan responses so you're not blurting things out, so you can keep your hands to yourself, so that you can complete tasks. A lot of these organizational tasks, and we see those as, it's a developmental disorder, and so the tendency in many children is to outgrow that as they grow up, but a lot continue to have some significant issues with these that affect their ability to hold down a job, their ability to maintain relationships. I mean, it's all kinds of aspects of life. It's not just about school, and I think that's a really important thing for people to understand. All of the research indicates that the benefits of treating this are life-changing.
And far outweigh the risks of
far outweigh the risks.
The risks of being on medication. What do we know about what is typically most beneficial? Something like the stimulant medications as compared to Wellbutrin or Strattera?
Yes, the literature is much more significant in showing benefit with stimulants when they're tolerated. Certainly there are some kids who don't tolerate them for different reasons. And so you have to kind of watch, because the side effects certainly can still be worrisome. Decreased appetite, problems with sleep are two that come up fairly frequently, certainly headaches or stomach aches, decreased problems. So the best answer is to really use the lowest effective dose that you can and find where that child is performing better.
And what are the implications then if stimulant medications are the best course of treatment for ADHD? We do know that there are a lot of people out there, a lot of adults out there, or young adults and maybe even teenagers who have a substance use problem, and they often travel down the road of abusing stimulants like amphetamines or methamphetamines, and yet they have ADHD. And so in the course of getting clean and sober, we also want to be able to treat their ADHD. What kind of a conundrum does that create then for a prescribing psychiatrist?
So that's a really interesting question. There's a couple of points I guess I'd like to make about that. One is that the use of stimulants is not shown to lead to substance abuse disorders, and I want to make sure that's very clear. It's a question I get asked a lot. And so treating a child who has ADHD with a stimulant does not make it more likely that they will grow up to have a methamphetamine addiction. I want to be very clear about that. In fact, the contrary is true. The conundrum that it presents for adults really depends on your ability to have a strong therapeutic alliance with that patient. It may really help them to have their ADHD treated in that it affects their ability to control their impulses. And having that ADHD treated well may enable them to kick their habit, hold down a job, be more effective in their lives, and really be able to move beyond that problem. However, the tendency, the temptation to abuse that medication also can be very strong. So you need to have a really clear contract. How much medication they're going to get. They're not going to be able to refill their prescriptions early. It is a controlled substance, and so that's very tightly controlled by the Drug Enforcement Agency, and so the access to the medication is tightly controlled, and that you need to make sure too that they're not diverting it, and that happens a lot too. So that it definitely is a conundrum. Often when you can try it once, and if it doesn't go well, you end up going with a non-stimulant for treatment. You may lose a little bit of effectiveness, but that I think we also don't want to be engaging in perpetuating somebody's
substance abuse
somebody's
problem.
substance abuse problem.
And so I think the comorbidity, when you have more than one diagnosis, it becomes a bit more tricky. And
Yeah.
I agree with Dr. Metcalf that the use of stimulants, when someone has a strong relationship with treatment in general, not just the prescriber, but also chemical dependency folks, perhaps a therapist, depending on whether they have mood issues or other things. Those things all need to be considered in the treatment plan.
And I think sometimes we're taking a look at there being a demonstrated commitment to treatment first before you venture down the path of potentially prescribing somebody a stimulant medication who at that point in their recovery may not quite be ready to handle that yet.
Exactly.
But what I like what you say though is that it's not a complete deal breaker either. And because in fact what we know and what you pointed out, Dr. Metcalf, is that increased impulsivity that you see with ADHD renders a person vulnerable for relapse to their substance use. And so it's kind of that constant balancing act then.
That's exactly right.
Absolutely.
What we're doing. I have a really great question here, and so I want to switch topics. Let's move away from ADHD and talk a little bit about post-traumatic stress disorder and medical interventions for post-traumatic stress disorder. There's a woman from Brimson who said, what about PTSD in military vets and others? Can they be helped by medicine?
Great question. I'm glad she clarified that it's in adults as opposed to kids, but both have had some research to suggest that mainly antidepressant medicine, but also some of the medicines that we were just talking about that are non-stimulant kinds of treatment for ADHD. One in particular, something called prazosin, has been quite well studied and found to be effective at reducing some of the autonomic overactivity that occurs when someone has PTSD. And combat vets, the thing I like to tell folks is this is 70 to 80% of the people who have been in Afghanistan and Iraq have symptoms of post-traumatic stress leaving that theater. And so this is actually more common to have those symptoms than to not. And this is something that I think treatment, again, needs to be multimodal, but medicines can make a big difference in helping someone find relief from some of those symptoms.
And so we know, one of the things that we know is that the prazosin in particular tends to target people who are having a lot of difficulty with nightmares.
Correct.
And tends to kind of knock those nightmares out, which then would, for some people, that's what they're reporting at least.
Yep.
That's what they're reporting in my office.
Yep.
And that allows them sometimes to get to get a decent night's sleep.
Yep.
And you ain't functioning if you're not getting a decent night's sleep.
That's right.
Well, and sometimes the nightmares themselves can be so distressing. People are afraid to go to sleep. Not just that they're not getting a good night's sleep and are tired, but that reliving the traumatic experience over and over and over again at night becomes that in itself causes so much distress. And this is a medication which has provided very good relief for a lot of people.
That anticipatory insomnia, which comes about when you start thinking, I know I'm going to have this again, and many patients tell me that they try not to go to sleep, which of course, as you pointed out, does not work well.
Yeah.
In treating post-traumatic stress disorder in children, are you using medications with them, or are you trying different things first?
So therapy is always, I think, the first line treatment for PTSD, both in adults and in children, and the medications are used more as kind of a auxiliary. It's something else that may be able to help, and you have to see what's going along with that trauma. We use a lot of this medication. I think Steve is referring to guanfacine, for example. It's one of these blood pressure medications. It's an alpha agonist, and it is very effective. I think what Dr. Bauer was talking about, quieting this autonomic system. This is the jumpiness, the called hypervigilance, where you
And the hyperstartle.
You startle, your startle reaction, you're twitchy, you hear a loud noise and you jump. This expectation, and this is interesting because it's very easy to confuse this with ADHD, for example. We see this a lot in kids who maybe they have both, but a lot of times when you see there's a history of some trauma, and they're reacting to every single stimulus they have by getting into this fight or flight response. And these medications can be really helpful at quieting down some of that jumpiness and really giving a lot of relief.
And I think what we want to say too is that experience of being that jumpy just makes you just so physically uncomfortable in your own skin that you start looking for ways to get away from that. And that's how I think particularly, you know, what we hear a lot, certainly in military personnel with post-traumatic stress disorder, is being comorbid with substance use. And substance use problems, but you know, you understand it when you'll do anything to get away from those feelings.
Very much so, and certainly depression also tends to run very strongly in those cases as well. And so there are several antidepressants. The group of serotonin-specific medicines, Prozac, Paxil, Zoloft, Luvox, Celexa, or their generic names, have all been looked at to some degree that way. And then there is an antidepressant that tends to make people more tired and contains some of that alpha agonist. Mirtazapine is the generic name of something that the company used to call Remeron, and that medicine in particular has also been something that I found very helpful with kids who have either a combination or severe PTSD.
How about in general medications for people who are anxious? So people who present with anxiety disorders, we want to sort of clarify there's a difference between just being anxious, because we all get anxious from time to time. That's not what we're talking about. But people who have anxiety disorders, first line of treatment medicine or first line of treatment therapy? Dr. Metcalf.
Well, it really depends on how severe it is. I think first line of treatment probably for a mild anxiety disorder, definitely therapy. However, when your anxiety is so bad that you can't even participate in therapy, or what all the research supports is that you really get an added benefit. You are more able to participate in therapy. You are more able to do the exposures, for example, that your therapist is attempting to work with you when you can turn down the volume a little bit in that anxiety. When we look at an anxiety disorder, this is the body, the brain in particular, but anxiety is very much in the body. And this is the brain misinterpreting these cues about danger in the environment. So something which physiologically our bodies have evolved to protect us from dangerous situations, and where we're misinterpreting somebody speaking sharply or an unknown person. Or
I always explain it like it's like you've got this teenage boy living in your brain who keeps running down the hall and pulling the fire alarm as a prank, because the fire alarm is supposed to signify danger, except that there's no, what makes an anxiety disorder is that the feelings of anxiety are disproportionate to the actual threat out there.
Exactly. And so if the medication can turn down the volume for that, that can be tremendously helpful. And then having the experience of then learning, okay, this is just a false alarm, I don't need to panic, you can begin to retrain the body gradually.
And what are the medications that we're typically prescribing for anxiety disorders?
Well, so the medicines that are listed as anxiety medicines tend to be medicines that have a higher abuse and or dependence potential. And so benzodiazepines as a class are medicines that have been around since the early 70s and are quite effective, but unfortunately as they wear off, it seems the body then winds up more anxious again. And so that's
and I just want to interrupt to say, and clients like those medications.
Clients like those medications. They work like stimulants. It's noticeable. The benefit is right there. And so in short-term studies, people rate these very highly. Unfortunately, as we try to use them longer term, it doesn't always go as well. And this is the part where Elena's exactly right. Turning down the volume initially, helping people get into therapy, but therapy remains the main treatment modality that effectively helps people deal with their anxiety. Medications are an adjunct.
And so they can be useful in certain circumstances.
They can.
Particularly in the beginning, so that, because what we're talking about is getting you to a point where you can do the homework that your therapist is going to ask you to do,
Yep.
or where you even can begin to feel that the deep breathing that you're being asked to do, that you can either think to do it on your own, or that it has any noticeable effect on you. I think a lot of people, will come in and say, well, that deep breathing doesn't work. And it's like, well, yeah, it does work, but you need to do it more often. And somebody's saying, well, if I'm panicking, I'm not going to think to do that.
Very much so. And so antidepressants similarly have been studied for generalized anxiety, for panic disorder, for those kinds of things. So again, the SSRIs, the medications for some of the atypicals work reasonably well as well. Atypical antidepressants, not atypical antipsychotics, though sometimes they're getting prescribed early in kind of the algorithm, and that at times we want to take a look at some of the other options. So many medicines will work on several of the systems, because when it is overloaded, when it's so prevalent that it's keeping you from doing things, sometimes we do need to use some stronger medicines that affect the GABA system. Anticonvulsants, where they were used first, have been quite helpful as well for people with really severe anxiety, but they're harder to take and they do have some more medical issues.
Pete, let's switch disorders to bipolar disorder. So bipolar disorders is one of those mental illnesses that may be a little different than anxiety, where a lot of people, we can treat their anxiety without them being on medication. Bipolar disorder is a more severe mental illness in general, even though there's range in the severity. You can have milder forms of it still, but in general that tends to be, we think of that as a more severe mental illness. And so let's talk about some medical interventions with bipolar disorder.
So that's exactly right. Bipolar disorder can be incredibly disruptive to people's lives. I mean, really life-shattering. Untreated mania almost always ends in the hospital, and it can be just incredibly devastating in people's lives. Somebody with a bipolar diagnosis, we'll recommend that they take an anticonvulsant or mood stabilizing medication for the rest of their life in most cases. There are the kind of gold standard, kind of old-fashioned at this point, medication for bipolar is lithium, which is incredibly effective for bipolar disorder. It's a little tricky as a medication, and so...
Now, I want to ask a question about this, because so here's what my experience is. What I've seen with my clients with lithium is that a great treatment response, and it has a shelf life because of the longer term use. The longer it's used, the more likely they are to develop side effects that either they can't tolerate or their primary care physician becomes more and more concerned about. And so my question then, so if I was calling in, this would be the question I would be asking, would be, does lithium in fact have, so that's my perception, that it has a shelf life, that it will only last, your body can only tolerate it for so long before it says, we are done with lithium. True, not true?
Lithium can be pretty hard on the kidneys in particular, and so it's one reason why I will very rarely start it in kids. Occasionally it's the right thing to do, and so there's always, what's the clinical situation, but it has what's called a very narrow therapeutic range, which means you have to check blood levels fairly frequently. Below a certain level, it's not effective. Above a fairly small level above that, it becomes toxic and can be and become very toxic to the kidneys. And so you have to be careful about not getting dehydrated, about not taking it with ibuprofen or other medications like that. So it's like I said, it's a little tricky, and it often does have to be discontinued once kidneys start to develop some damage from that. We've gone increasingly to using anticonvulsant medications, so medications that would otherwise be used for epilepsy as mood stabilizers, and examples of that would be like Depakote, and also a lot of atypical antipsychotics.
And Dr. Power?
Yeah, and so thyroid is the other thing that seems to be affected quite a bit by lithium. And yet, having trained back in that era where Depakote was brand new and we weren't using it as much, but started using it a lot, I've met patients who have been on lithium for a very long time, and we've tried to switch them, we've tried to do other things for them, and lithium winds up being a treatment that actually does have reasonable response. And as older clinicians used to tell me, we can always treat the thyroid problems if those arise. The kidneys not so much, it gets harder, and so that's when we really start getting into that shelf life piece.
We are out of time. I'm about ready to get the signal here. So what's the take-home message? There are a lot of mental illnesses out there for which we have excellent medical interventions, but what are you going to need? You're going to need to have a good physician, and you're going to need to communicate with that physician, and then you're probably going to need to try something that's going to feel a little scary to try. That's kind of how this works. You all called in a lot of questions about sleep. I took none of those questions. You know why? Because we are doing an episode explicitly on sleep in a few episodes. I think it's at the first of the year. So you're going to want to tune in for that episode. Thanks so much for joining the discussion this week. And don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links. And join us again next week when we'll be talking about letting go of toxic shame. I'm Dr. Carolyn Phelps. Thanks for watching, and good night.